Ms. Scott.
No.
So Dr. Gabra, I'm going to ask you some questions now about hepatitis. What did you understand about the risk of hepatitis being transmitted by blood and blood products when you took up your post in Glasgow and in those early years?
Yes, that there was still a risk of hepatitis transmitted to patients of hepatitis B, and also of another type of hepatitis, which was called hepatitis A, non-A, non-B hepatitis.
What was your understanding of the role of pool sizes in a product's infectivity, level of infectivity?
Yes, may I add here that, for instance, plasma that was used at some stage was heat treated and was assumed to be does not transmit hepatitis, but the known type of hepatitis, the hepatitis B. But the hepatitis C, the non-A, non-B, was still there. So your question is about
pool sizes.
The pool sizes, yes. The more you give donors, the larger the pool size, the higher the risk of transmission of infection.
And when did you first become aware that infection with non-A, non-B hepatitis could lead to serious consequences such as cirrhosis and cancer, hepatic cancer?
Yes, I think I was aware that it is different from hepatitis B, and the pathology is different, and then we realized that this was linked to the type of hepatitis that was hepatitis B negative, and the risk is higher. I mean, and the liver hepatitis, the hepatitis, and the hepatitis, the cirrhosis and the cancer was higher in the type of hepatitis that was hepatitis B. So we became clear that that was. Your question is about when?
Yes.
I think we started to have an idea about this when we started to see that kind of difference between the patients with hepatitis B and the patients with hepatitis C.
Were you aware, for example, of Professor Preston's work in 1978? He published a paper in the Lancet in which he'd biopsied people with haemophilia and discovered cirrhosis and so on. Were you aware of that paper in 1978?
I might have read it, but I'm not aware of it now. I think this is when probably we started to think that there are different types of hepatitis infections that we are transmitted to our patients.
I'm going to ask you a question about the practice of the selection criteria for hepatitis at Glasgow. So we just look at a document to do that. It's PRSE 301327. And we can see here, it's called Guidance for the Selection of Blood Donors. And it says the following guidelines represents the collective opinion of SNBTS. They may be varied at the professional discretion of the medical officer or sister at the session, having due regard to the welfare of donors and the safety of recipients. And the decision to accept or defer a donor at its session rests with the medical officer or sister. And this version is dated November 1988. Is that a familiar document to you? Was that the guidelines that were used in Glasgow? Can you recall? They were the national guidelines.
Following guidelines, I'm just looking at it carefully. They may be varied at the professional discretion. Yes, and that was a concern, actually, not only in Glasgow, but that there were no, that the guidance were not clearly cut, and particularly when they were medics, doctors, that it is likely they use their clinical discretion, because while when we have sisters, we have guidelines for them, and it's very clear. And if it says, if you do this and this and this, it's acceptable. If you do this and this and this, it's not acceptable. So the performance of the person who is selecting the donors depended on the availability of clear guidelines for selection and deferral.
Can we turn to page 11 of this document, please? Now we can see that the guidelines run from A through to Z with different conditions, if you like. Again, does that look familiar to you? Do you think those are the guidelines that were in use in Glasgow?
I suppose that if the date puts it into Glasgow period, my Glasgow period, yes. But this is why I'm not saying I am familiar with this one, because it has become a normal part of this particular activity, that it had to be put into that kind of document for people to follow, rather than depend on their clinical acumen. That is to say, we want people to be guided by clear criteria for selection.
I'm just going to read out the bit about hepatitis and then ask you a question to see whether you can remember what the practice was in Glasgow. So it's at the bottom of the page there. So if somebody comes presenting with hepatitis, the instruction is childhood jaundice stroke hepatitis with full recovery, accept. Jaundice, hepatitis B, consult sister or doctor. And then note for sister or doctor, defer and obtain more information from GP, may be acceptable 1 year after full recovery. History of hepatitis B usually debars, refer to centre. So we can see there exactly what you've just been talking about, Dr. Gabra. There's a discretion, and we've heard different evidence from different witnesses about what they did at their centres. Can you remember what the practice was in Glasgow?
I understood that this document was from Glasgow, from Scotland.
It's for the national. It's an SNBTS publication.
Yes. So we should have been using this.
Okay. So, but you don't. But you can't assist us as to how the discretion would have been exercised. Can you remember how the discretion was exercised?
When the discretion is actually controlled by what the note that says defer and obtain more information from GP. I think it has reduced the discretion. Like, for instance, childhood jaundice hepatitis, you will think that this is normal if it is full recovery. And jaundice and hepatitis B, you have to consult the sister or doctor in order to make the decision to defer.
So I'm going to ask you some questions now about the steps taken to produce hepatitis reduced or hepatitis free products. And I'm going to start off by looking at your involvement in the Factor 8 study group. And I'm just going to ask for a document to come up, please. PRSE 301684. So this is a letter not to you, it's to Dr. Prowse, dated the 17th of December 1981. It says, "Dear Chris, I am forming an SMBTS Factor 8 concentrate study group, which will have the following members," then sets out a number of people from PFC, the Edinburgh Centre, and yourself. And it says, "The remit of the study group will be to explore new developments in the widest possible sense with regard to the production of Factor 8 concentrates, and thereby create the opportunity for cross-fertilisation and for coordinated research within the SNBTS." Do you know why you were invited onto that group?
Yes, because at that time I was interested in exactly how to improve the quality and the safety from the products that we are producing, which was the cryoprecipitate at that stage in Glasgow. And I was working with the team in the Royal Infirmary, and I was working with, I think, John, in order to have to prepare for a master's degree or something like that, which I didn't complete. But it was, they knew, of course, that I was doing this, my colleagues in Edinburgh, and that's why they asked me to join them, exactly to make sure that we, as Scottish work, we get together and see how best to do it. And I think there was another gentleman from Malta, I think, who is now working in I can't remember where he's working, but he's working in the south, and he was not concentrating on. He was mainly concentrating on the details of the storage, the heating, the freezing, and in order to improve the quality and the amount of Factor 8 in the product.
And the work that you were doing was in relation to freeze-dried cryoprecipitate, was it?
Yes.
And I'll come on to ask you questions.
And the standards for the management, for the measurement of Factor 8 content of the products.
And was it a useful study group? Was it helpful?
Well, at that stage, I was very excited about it because it has linked me with different people, and I think it resulted in if I remember correctly, for a study to use the cryoprecipitate that was produced in Glasgow, and to make sure that the idea of the small pool products is something to consider while we are in the transition period from ordinary cryoprecipitate into the Factor 8 derived by fractionation, which is a large pool, on the assumption that small pool will be less exposure.
So let's turn then to look at one of the documents, one of the reports that you produced about freeze-dried cryoprecipitate. Could we have, please, PRSE 301701? And here we've got a report on the production of Liophilised cryoprecipitate by yourself, dated January 1980. And if we go over to page 1, we can see what it says, introduction. The simple method of preparing cryoprecipitate ensures a continuous, reliable supply of factor VIII prepared at minimum expense in any transfusion centre. And then you set out below that the number of donations sent to PFC from Glasgow, and we can see that number between 1974 and 1978 is increasing. And there's a corresponding decrease in the amount of blood donations that the centre is processing itself as cryoprecipitate. Is that what those figures show?
Yes, and that is normal because in a previous question that you asked, the facilities were not available, were not enough to increase this. And the quality of the good manufacturing practice criteria, we were not able to achieve in Glasgow. And also it was becoming nearer the time when viral inactivation procedures are being around the corner. And so the PFC produced product would have been the best to follow, and that is what has happened. The decision was not to follow the idea of cryoprecipitate because it reduces the extent of infection, and rely on the plasma fractionation, large products, on the assumption that we are going to it's around the corner, the use of viral inactivation. And so it made sense, I think. When we have to change the whole service in order to stick to an idea of cryoprecipitate, and it's very, very small amount, and it wasn't practical at that stage. And that's why, although I wrote this, it was the thing to be said at that stage, and I was excited about it.
So if we look down at the bottom of that page, you set out exactly why you're excited about it. The preparation of dry cryoprecipitate is a reliable technique that has now been successfully adopted by many transfusion centres outside the United Kingdom. This dry product should have most of the advantages of the dried NHS factor VIII concentrates, namely the long shelf life, the easy storage, and the predetermined dosage. It also has the added value of being simple and economical to produce, and carries reduced hepatitis risk, being prepared from, if we can go over the page, small pools of donor plasma. In short, it is an improved method of storing and dispensing cryoprecipitate. These are the thoughts that led the production team at Glasgow Blood Transfusion Centre to explore the possibility of introducing a lyophilized small pool factor VIII rich product called Liophilised cryoprecipitate by pooling cryoprecipitate from 5 plasma donations and freeze drying these small pools.
Yes. I think I'm when I'm reading this now, and when you're reading it, I'm becoming aware that this situation is now the situation in many countries in the world, actually, where they have no facilities for fractionation. They can only rely on their plasma, and they can produce it. It's called low. It's not a complicated procedure. It can be done in any transfusion center, rather than having to go to wide, high technology fractionation of that is not available in. So we were at that stage. At that stage in Glasgow, we were in the stages that we are still now in many parts of the world, and they are using this because they can produce it in their lab, proper lab, small lab. They can rely on and they don't have the facilities to buy it to buy the product from the United States or Europe, and also they have they can access this very easily.
So then, if we can turn to another document which sets out, which is a write-up of the clinical evaluation of this product. It's WITN 4035008. So we can see here, this is an article written by you, but we can see it's called Freeze-Dried Cryoprecipitate, a Clinical Evaluation, published in 1983.
Yes, it is. It's not written by me. It's written by the group led by John Davidson from the Royal Infirmary, with whom I used to work.
And it says, the summary says, freeze-dried cryoprecipitate was used in the treatment of 14 patients with haemophilia A. The in vivo recovery was 91.2%, which is comparable to that reported from other parts of Europe. The product was efficacious and no adverse effects were reported. Freeze-dried cryoprecipitate is the high-yield product of a low-technology process, and as such may be of value in reducing any possible shortfall in the factor VIII requirements of the haemophiliac population of the UK. If we then turn to some of the detail, we can see over the page 2, under patients, 14 patients with haemophilia A and without inhibitor to factor VIIIC were recruited from the haemophilia unit of the Royal Infirmary, Glasgow. Informed consent was obtained for all patients prior to entry to study. Patients were given a dose of factor VIII, nominally 800 international units of factor VIIIC, in the form of freeze-dried cryoprecipitate prior to dental surgery. 2 patients each received freeze-dried cryoprecipitate on 3 occasions. In total, 19 doses of freeze-dried cryoprecipitate were given. The freeze-dried cryoprecipitate was prepared one year prior to the start of the study. In all other respects, the patients were managed in accordance with the current practice of the haemophilia unit. And then if we go to the second column on that page, discussion, they look at the bottom of the page at the disadvantages of it. They say the major disadvantage with this product, as with conventional cryoprecipitate, is the wide variation in factor VIIIC from unit to unit. In this study, factor VIIIC ranged from 3.2 to 6.2 international units per milliliter. However, the mean factor VIIIC actually given, 860 international units, was similar to, if we go over the page, factor VIIIC nominally present in the 200 ml dose, 800 international units. A minor disadvantage, especially for home therapy use, is the volume of the reconstituted product. And then it goes on to give the details of that. And then setting out below, however, the excellent yield and the simple low-cost technology required for its production make this product suitable for further consideration in the UK if the National Health Service protein fractionation centres are unable to meet the demand for factor VIII, with the consequent reliance on commercial imported sources of factor VIII.
Yes.
So presumably you would add to that advantage the fact that it's lower risk of transmitting virus.
At that stage, yes. At that stage. Yes, at that stage.
And is it, I think you've already alluded to this or said this in your evidence, but is it right to understand that the reason why this didn't go any further was because the freeze-drying plant, the freeze-drying facilities at Law were closed down?
Yes.
And that was at the end of 1982, is that?
Sorry, can I?
Yes.
And there was no facility, and that was at the stage when the facility in Edinburgh was not available. Am I right? I think the dates would suggest this, the dates of writing these papers. I think it was just before the decision to have the fractionation facility in place.
Do you know whether any consideration was given to improving the freeze drying facility and trying to bring it up to scratch?
Yes, yes, I knew, and we had figures for these changes, and it became clear that it is not worth doing when we have round the corner the facility to improve what was happening in Edinburgh, and also to make sure that we are looking not very far off from having viral inactivation procedure that will actually reduce the major issue, that the claim of this product, that it is because it is low, it is a small pool product. So if we have a facility that can deal with a large pool products and the resources are going to be available, and it is going to be viral inactivated, then I think it makes sense not to look at the needs of current countries in the world that have no resources.
So we know from other information that the freeze drying plant was closed at the end of December 1982 or January 1983.
Yes.
Can you remember whether there was any discussion about the fact that AIDS was becoming known at that stage, and that it might be a good idea to try and keep the plant going because of the risk of AIDS?
No, I think I remember discussions with Radvin Mitchell asking him, why don't we try hard to get this to cover the period that we are going through at the moment, and have some facilities for this. But when we discussed it, it became clear that there is no point in having this done. So it was clear that we will have the facility for fractionation, and also that viral inactivation will be there to rescue the patients from worry about transmission of infection through large pool products.
And it was Dr. Mitchell, was it, who was expressing the view, don't worry, viral inactivation is round the corner?
No, it wasn't known. It was known to everyone that things were happening. Yes, things were happening.
So that was the understood and accepted.
Yes,
by all your colleagues, you and all of your colleagues.
Yes. In fact, we have been using also heating the plasma before producing the cryoprecipitate, on the assumption that is going to kill the virus or the viruses.
Is that what you were doing when you were doing the freeze drying?
Yes, yes.
You were heating it and freeze drying it.
Heating the plasma and doing it.
And what did you know? Can you remember what method of viral inactivation was thought to be around the corner?
Can't remember exactly. Sorry, I beg your pardon.
I'm going to ask you some questions now about your knowledge of AIDS. Can you remember when you first became aware of AIDS and its association with blood and blood products?
When we heard of what the transmission of wasn't called AIDS, but the transmission of this virus to some people in the United States, but I can't remember exactly the paper that was written where this was reported.
Many witnesses have. There seem to be two standout papers that lodge in witnesses' mind, and I wonder if this helps you. If this helps you at all. So often witnesses say it was when they heard about a baby contracting AIDS after a blood transfusion that they understood there was a link between AIDS and blood products. Do you remember that?
I can't remember this paper.
And the other paper that is often mentioned is one was written up where 3 people with haemophilia contracted AIDS after using factor concentrate.
Yes.
That's one you recall, is it?
Yes.
And do you remember when you read that paper or heard about that paper, do you remember whether you, at that point, were clear in your own mind that that AIDS was caused by an infective agent carried in blood?
Yes.
And was AIDS and the risk of AIDS from blood and blood products something that was discussed amongst you and your colleagues at the Glasgow Centre?
Yes, it was discussed all over the world, I think, not only in Glasgow.
Were you at the Glasgow Centre asked to increase production of cryoprecipitate in response to the AIDS crisis?
I would say that we were not asked, but it became clear that we have to do that. But it is possible that we were asked. When the directors sat together, they decided that this is something that we have to look at.
So is this right? You don't know whether you were asked. You may have been, yeah. But it became clear at some point that cryoprecipitate production must increase.
That's all what we could do in Glasgow, but we can also have in mind to produce extra plasma to be fractionated somewhere else, to increase our plasma collection. And I seem to remember that was the stage when we started to think seriously about having the plasmapheresis. And it wasn't a Glasgow only decision, it was a national Scottish decision, I think.
Would it have been possible to increase production of cryoprecipitate at Glasgow if you had been asked?
No, we knew that there were limits in space, limits in facilities, and limits in access to resources that will take time to come in order to produce it. But we were doing, if you remember the figures that you showed us now, it was that what I think was the maximum that we could have done with the existing facilities.
And that's the collection of the figures we looked at from 1974 to 1978, the production of cryoprecipitate.
Yes.
Those figures we looked at. So to have increased that above that level would have been difficult. Is that what you say, because of the lack of space and equipment and so on?
Yes. And the GMP requirements in particular.
And had Glasgow been committed to doing that anyway, do you have any idea how long it would have taken to be able to increase cryoprecipitate, to put in place those steps?
I'm sure that this was discussed, and I'm sure that I had my thoughts about this. But all what I can say really is that it would have taken a long time to establish the facilities in order to increase the cryoprecipitate. When we have fractionation somewhere, I think in the country, and we could build the fractionation, improve the fractionation facility in Scotland.
I'm going to ask you some questions now about the material produced and used at donor sessions in Glasgow once the AIDS crisis had become evident. Can we look, please, at PRSE 304816? Here we've got a leaflet from Glasgow, and it says, "Thank you for attending for blood donation. It's desirable that you should give blood only if you are in normal health." And then it sets out a number of questions that the donor must consider, including whether or not they've had an infectious disease, etc. Then if we go down to 6, have you had any serious illness? And it sets out a number of illnesses, including jaundice, and a number, and at the bottom deals with age limits and anemia. And then there's a stamp at the bottom. Have you heard of AIDS, acquired immune deficiency syndrome? If you have any doubts about giving a donation, consult the doctor at this session or your own GP, or write in confidence to the regional director. And then it sets out Dr. Mitchell. It says to the right, Dr. Mitchell is the director. Now, if we go right to the bottom of the page, there's a handwritten date, 16/6/83. There's material to suggest that this was in place in Scotland, in Glasgow, sorry, by the end of May 1983. I don't think we need to go to it, but for the transcript, there's a meeting of the SNBTS, PRSE 303620, where Dr. Mitchell says that he put this in place. So is it right, looking at this leaflet, is this a leaflet that was handed out to donors at sessions?
Yes, I think that was the use of this document.
And it looks like what's happened is that there's a leaflet which doesn't mention AIDS, and then a stamp has been put at the bottom onto the old leaflet. Is that right?
Yes, it looks like an added in a rush sort of thing, rather than having to wait and print. I'm not sure. The papers of the early phase cases, was it 80 or 82?
So the cases that I was mentioning to you earlier was 1982.
1982.
The baby case, for example, was reported at the end of 1982.
Yes. I'm just putting a link between this in a rush sort of document until I think after that there must have been something else which was discussed but with the directors in order to have something proper.
Do you remember anything about the reaction from donors to this leaflet being handed out with mentioning AIDS on it?
Yes, many concerns were raised by donors. One of them is actually being infected if they come to give blood.
You've told us in your witness statement that Glasgow used the leaflet that Dr. McClelland in Edinburgh drew up.
Yes, I think that probably came after this one.
And so, again, we don't need to go to that, but the reference for the transcript of that leaflet is, I'll just check I've got the right reference actually.
I hope it was
is PRSE 304850. I don't think we need to go to that. We've looked at it in other hearings. We've heard from other witnesses that in their transfusion centres, they had opportunities for donors who realised partway through the donor session, because of material they've been provided, that they're high risk and they shouldn't donate. Opportunities for them to be able to exit the donor process without confidentially, without it being obvious.
Yes.
What they're doing. Were there any such opportunities in Glasgow? Were donors able to exit the session partway through the donation if they realised that they were high risk?
I honestly can't remember that this was the fact, but it sounds as though in my mind that this is the right thing to do, and that's probably when I mentioned confidentiality, and has to be done with a lot of care, not to cause. Not to let the donor, if he's going to go out, everybody will know that he is going to be, that he is suspected of having this disease. And there are ways of that have happened, but I can't remember when, that where people have taken the unit and with a label that this is not to be used. And I'm not sure when did this start, whether this started when I was in Glasgow or when I was in the WHO, because it would have been a major problem in countries where there is no confidentiality. People are sitting together and chatting about everything. So I'm not sure exactly how to say when this has happened, but this is quite a sensible thing to make sure that people are not,
Can we look now at another document, SBTS 40169_079. So we got here, oh, that's not the right, sorry, SBTS. No, that's not the right document. Try this one, SBTS 40680_171. Yes, that's the right document.
Yes.
24th of April 1987. It's a letter from you to Dr. Mitchell. And you're talking in the beginning of the letter about clause 4 of the National AIDS leaflet, and I don't need to trouble you with that. It's the third and fourth paragraph I wanted to ask you about. So you say this: I also feel we have no option but to accept the word of the donors as truthful. This is the paradoxical strength of the voluntary altruistic donor system. and its major weakness, it is impractical and unworkable to consider the donor's answer to our checklist as suspect because they are compulsive liars or embarrassed by their colleagues or wives, etc. So just pausing there, can you recall, or does this tell us anything about the view that was taken by Glasgow, the donor attendants and the clinicians, at the centre, about the way that they must treat and deal with donors?
I think from the letter you can feel that I was totally convinced about this approach from donors, to make sure that donors are not embarrassed or put into a situation that is not comfortable for them. But in the same time, we have to make sure that there are other ways to deal with infected donations that come into the system, which are not written in this letter. But I am actually defending the relationship between donors and the service, that we have to accept that they are truthful in what they say, and that it's our job to make sure that our products are safe.
And you say, you go on at the last sentence there, clause 4 is clear. It does not require embarrassing questioning or inquiries by the medical staff. Either it applies or it does not. Was there a sense that asking donors about, for example, their sexual practices would be embarrassing and shouldn't be done? Well,
at that stage it was. At that stage, that's why I felt that these are all embarrassing things for the donors. And if it has to be done, it has to be done in a very careful way, and to make sure that the donor is not offended, and also that our patients are safe. And there must be a way, and we have lived with that all the time since the appearance of the AIDS epidemic that happened in that time.
And so
we have lived with systems that allowed respect for the donors and also safety of the patients.
And what you're there saying is, look, these criteria need to be really clear so that it's not necessary for donor attendants to have to ask questions, and it's not necessary for donors to have to ask, do I fit into this criteria? I can't work it out.
No, I don't think so. I think we have to do it, but it has to be done in a very special way. And how are we going to accept that they are saying the truth? We are not able to say that if they are saying the truth or not. And that's why I felt that it is important to make sure that this is done in a very special way, in order to help them to think properly about the question, and also to be honest in their and this happens all the time with donors. We have to encourage them to think about what has happened yesterday, last week, sometimes when they were on holiday, etc. We have to provide them with the environment in order to get from them the truth.
Can we then look at a document which helps us understand the impact of AIDS literature on donor numbers at Glasgow, and that's SBTS 5033_033. Now, this is a letter from Dr. Mitchell to Dr. Cash, dated the 4th of March, 1986. And it says, at the directors' meeting last week, there was discussion about how we might investigate the adverse effects, if any, on donor preconceptions about unwarranted fears of contracting AIDS by giving blood. For what it's worth, I would like to present the following data from October 12 to the end of December 1984 and similar period in 1985 to compare the 3 months after the introduction of the test for anti-HTLV3 with the previous year for the same period of time. And then he sets out the figures so we can see that in 1984, 49,568 donor call letters were issued with donor attendances at 71%, and 1985, many fewer donor recall letters were issued, 39,185, but with an attendance of 86%. And then the conclusion that Dr. Mitchell draws is set out below, and he says, you will see that, as I previously indicated to you some months ago, the figures do not suggest that there has been any major loss of donors as a result of the HTLV3 publicity. Is that how you remember it?
No, but the figures don't say this. But I remember that there was a drop in the donors, and this has not only happened in Glasgow; it has happened in many places, and it has stayed for a long time actually in many European countries as well. And it was very difficult to persuade them that when they come to give blood, they are not going to be infected. Did I answer your question?
Yes, you did. Thank you. I'm going to ask you now about HIV screening. Can you recall whether, when HIV screening was introduced nationally through the blood transfusion centres, whether in the Glasgow area, west of Scotland, Glasgow and west of Scotland, was there screening in the community as well? So at GPs or sexual health clinics?
I'm sorry, I hear your question, but I couldn't.
Yes.
Exactly.
Can you recall whether there was screening for HIV in the community
yes.
at the same time as there was screening in the blood service?
Yes. And that was also a worry, that people will come to the transfusion service in order to have the screening done without saying that I'm coming to make sure that I don't have this infection. And that was quite a problem actually.
And was there screening? Could they go elsewhere to the GP or the sexual health clinic?
I'm not sure about that, but I knew that there were people who used to come to transfusion service, and that's why in some places before introducing the testing in the service, they made sure that it's available for the community outside.
Can I turn now to a paragraph in your witness statement? If we just have that up, it's WITN 5495001. And you're being asked questions about what counselling and psychological services. Oh, sorry. So that's your statement. If we could turn to page 40, please. You're being, and I want to look at paragraph 146, but just to put it in context, you're being asked questions about what counselling and psychological services were available for donors who tested positive for hepatitis or HIV. And you say this: details of the donor were referred confidentially to a senior member of the medical staff adequately trained in counselling procedures. Now, just pausing there, was that you? Or was that one of your colleagues?
Not only, yes, that was, yes. And we used to have a session to discuss the donor care in cases that the donor is referred properly and handled properly without just making sure that he's properly handled and taking good care of him and having all the following steps available in order to make sure that he's given all the care that is required.
Sorry, I asked you a question which wasn't very clear. My fault. Was that you, the senior member of medical staff, adequately trained?
There were other colleagues who were doing that. I remember two other consultants who were doing that.
As well as you?
Yes, yes.
And we've heard from other witnesses about accounts about a training session being delivered in St Mary's Hospital in Paddington, London, yes, for HIV counselling. Did you go to that training session?
Maybe that I have gone, but I'm not sure.
Okay. And then it goes on. Communication with the donor was conducted using a specially worded letter with an invitation to come to the centre to repeat testing of a fresh blood sample. And then donors, once confirmed positive for HIV findings, were invited for face-to-face counselling in the presence of an HIV counsellor to be taken over for management at one of the specialised NHS departments in the region. Donors with false positive results were also informed without delay and reassured on the telephone. So it's I want to ask you about the face-to-face counselling in the presence of an HIV counsellor. So what can you recall about that? Who the HIV counsellor was, yes, what their role was?
By this time, I was in Birmingham, and there were established units to manage patients with HIV infection. And we had access, we had made an arrangement in order to invite one of the counselors from this unit to come and attend the meeting with the donor to make sure that that person that donor will be followed up by someone who has already met him. That is to say, there will be continuity in the follow-up of this donor. And so that was not a member of the national blood transfusion. He was the person at the end of the day who would be looking after this person when he is referred to the center, and of course after agreement of the donor that this is going to take place. Can I add also something about the training and my training and the training? Why I remember I haven't attended the document of the WHO, by the way, about counseling donors before giving blood, that was issued after the AIDS problem. I was member of this leaflet that was produced by the WHO, the Global Blood Safety Initiative, and I participated in writing this paper. So that was probably the way I was considering myself. In some way, I had some training in counseling.
I'm going to ask you some questions now about high-risk donors. Did you attend sessions in prisons? Do you recall?
No, never. And I was from the start unhappy about going to prisons because we believe that donors are voluntary donors. They are not donors that are they can say they are quite free to say yes or no. Or there may be other incentives for them to come and give blood.
So you were worried that they weren't truly voluntary if they were prisoners?
Yes, yes. They are. There is another word for them. They are not free donors.
were you aware that Glasgow was the last centre to phase out prison donors?
No, I was surprised.
And were you able to speak to Dr. Mitchell about your concerns about prison donation?
Yes, I've said that. No, not about prison donations, but about the voluntary aspects of donations in general.
But you didn't speak about prison donation.
I really didn't know while I was working there that it was one of the other sessions that they go to.
Okay, so you weren't aware they were doing sessions at prisons?
Because I also thought that this is a national thing, not to have sessions in prisons.
Do you know whether or not there were any sessions taken for military personnel at military barracks or the like?
Yes, I knew that it is taken, yes. And because I think there was a separate transfusion service for the military forces.
And did you?
But later on, that was stopped, and they were supplied by the service.
And did you have any concerns about whether or not that those donors were truly voluntary?
Well, in my way of thinking, yes, they're not supposed to be pushed into or asked, yes, sir, I'll have to go and give blood.
I'm going to move topic now to surrogate testing, in particular to ALT testing. Is it right to understand your statement that you thought that ALT testing was introduced in Glasgow?
It was introduced, but not to be used. It was introduced, I think, as an exercise and a research exercise.
So it wasn't introduced as a screening test.
No,
across the
no, it wasn't.
surface.
The virology department was interested in looking at this, and I think there was a paper published that was in the time of John Wallace.
I'm going to move now to your time as the blood program advisor to the League of the Red Cross and the Red Crescent Societies. Can you just tell us a little bit about what that involved?
It was part of, as the name implies, it's a global blood safety initiative. And it was in many ways using the HIV epidemic to make sure that blood products are safe from any other viruses, that is to say, including hepatitis B and non-A non-B hepatitis. And this meant that 3 things: to make sure that the testing procedures are available, the blood supply is as safe as possible, and reduce the use of blood as much as possible. I think these are the main factors, and so it was a international program where we visited the countries. We checked what are the requirements in order to provide them with testing facilities and guide them to the proper use of blood and making sure that donors are cared for.
So if we look at one of the consensus statements that you were involved with, it's NHBT 5030_048. And we can see that Global Safety Initiative consensus statement of screening of blood donations for infectious agents transmissible through blood transfusion. And we can see what it is. The Global Blood Safety Initiative is a cooperative endeavour to support the development of safe and effective blood transfusion services in all countries. and then sets out who the core participants are. And then the second paragraph, this document was reviewed and endorsed by the GBSI consultation on screening of blood donations for infectious agents transmissible through blood transfusion, held in Geneva in January, February 1990. 16 specialists in transfusion medicine and hematology from 12 countries participated. The participants are listed at the end of this document. And if we go then to page 12, we can see who that includes. And there's a list of participants, which includes from England, Dr. Allah, the director of the West Midlands Regional Transfusion Centre, and Dr. Barbara. And then we can see various other participants from America, France, Gambia, Finland, Australia, etc. And then if we go down to the bottom of that page under the Secretariat, we can see your name, fourth down, Blood Programme Advisor, League of Red Cross and Red Crescent Societies, Geneva. And there are a number of other members of the Secretariat which go on over the other page as well. So if we turn back then to page 1, we can see the aim of the document under introduction. The aim of this document is to provide guidance for formulating policies to reduce the risk of transmission of infectious agents by blood and blood products. This includes careful selection of blood donors and performance of appropriate screening tests. And then if we turn, please, to page 6, we can see that various recommendations are made. We go down the page. First of all, about HPV, which I won't trouble you with, and then non-A, non-B hepatitis. And it says, it's recommended there should be studies of the epidemiology of HCV infection throughout the world. Due to the serious nature of HCV-related disease, it's desirable to screen blood donations for anti-HCV. It says anti-HCV tests are available but expensive, and there is an urgent need for development of less expensive screening tests. So just pausing there, what seems to be suggested, is this right, that hepatitis C testing is desirable, but because it's expensive, it's not mandated. Is that right?
It's not, yes, it can't be available for those countries.
So is it right? So the expectation is it that if a country can afford HCV testing, they really ought to be doing it?
Well, I'm afraid that this is the problem. It's not my answer, it is the problem, actually. And I can see that number 3, they are suggesting use the ALT, I think, and anti-HBC.
Can you remember whether number 2 was a controversial recommendation, or whether that was widely accepted?
No, it's not. Well, anti-HCV tests are available but expensive, and there is an urgent need for development of less expensive screening tests. So they are actually asking people to look at less expensive screening tests because they cannot afford, these people, they cannot afford to have the test. So it is a problem.
I'm going to turn next to your time as in Birmingham in the West Midlands Centre.
Just before we do, the date of that, it's the document has on it 91-1 at the top, which would suggest it was a 1991 document. Do you have any information as to the precise date?
You're asking me?
No, I'm asking council.
Sorry.
Yes, so the only information we have is that the bit that I read out on page 1, which says that this document was reviewed and endorsed by the people we looked at a meeting held in Geneva, 30th of January to 1st of February 1990.
Right, so 1990 document, and we have Dr. Alla and Dr. Barbara both signing up to a document which suggests that the blood, that HCV testing should be introduced, in effect.
Yeah, yes, that's correct. Moving on then, Dr. Gabra, to your time in Birmingham and the West Midlands, just to remind ourselves of the timetable, of when you arrived in the West Midlands. So you arrived there in 1992. Was Dr. Alla the centre director when you arrived?
Yes, yes.
And had he been in post since 1982?
I can't remember when he was there. No, I can't remember.
And you tell us in your statement that the headquarters of the centre itself were based in Birmingham, but the centre had 3 static sites, 10 mobile blood collection teams, and annually collected 250,000 donations, or approximately 10,000 donations a day.
Yes.
And it formed part of the Western Division of the Blood Transfusion Service. And so you attended some of the Western Division meetings.
Yes.
And I think your witness statement also tells us that the the population that it covered was 5.2 million, with 24 regional and university hospitals being serviced by the centre.
Yes, I, as far as I remember, these are the figures.
And you also tell us that as a consultant in the early years there, you were responsible for clinical aspects of irregular antibodies and red cell serology teams, the medical aspects of blood collection and donation teams, which involve clinical support, counselling, including follow-up plans for clinical support, care of donors with transfusion-transmitted infections, and referral of such donors for appropriate management, as well as liaison with all Midland hospitals and the promotion of the activities of the transfusion committees. Were those, broadly speaking, your areas of responsibility?
I was what? Sorry?
Was that, broadly speaking, your areas of responsibility?
Yes, yes.
And then once you became the lead medical consultant in 1995, you became responsible for the coordination of all medical matters in the centre and with the hospitals in the region.
Yes, with the assistance of my consultant colleagues. That's to say, they were looking after bits and pieces around.
Just before we break for lunch, I wonder if I could just ask you some general questions about your impression of the differences between the service in England and the service in Scotland.
Well, first of all, I think that it's difficult to compare them because they are different age groups. One of them was in 80s, and the second one is 92 or something like that. So it's not difficult, but it is not the same level of where I can say this compares to this. But in general, I think that I could feel that what is happening in London, in Birmingham, is a much smaller is a much larger. What's happening in Birmingham as part of England is a much smaller unit compared to what is happening between Glasgow and Scotland. So because in Glasgow it was almost half of the population, but in our case in Birmingham it was 10% of the population, sort of thing. I could feel that many of the things that I found very difficult and needed to be changed at that time in 1982 are not a problem, because we are simply concerned with the production, the collection of blood, a much closer relationship with the hospital teams. We have hospital transfusion committees. That term was created, which was an excellent thing that John Wallace was trying to establish over there, and also that the running of the services were in a much better shape compared to what I have been working with in Scotland in 1980. So there was a difference, and I am assuming that, I remember that when we were in Scotland, when the UK was trying to introduce serious quality assurance systems, there were many people from Scotland who were invited into Birmingham in order to tell them about what they are doing regarding quality. But that was, again, not in 82, but it was in the late 90s, sort of thing. I think that's all what I can say. If you want to ask me specifically about other issues, there was no facilities for repairing other than components, platelets, etc., and blood, etc. But in Birmingham, there was the facility for almost some time of fractionation and plasma production in order to be sent to the army that's all, for the use of patients who have been who need emergency volume expansion using plasma. So it was a different setup, what is happening in Glasgow, while the modern approach to transfusion practice was available in Birmingham when I went. At that time, it was not. It was the future of what was happening, what was to happen in Glasgow, and it so happened that by creation a new center, which wasn't using, and the facilities for fractionation was left to the industrial type of service rather than the clinical hospital-based facilities.
So I note the time, sir. It's just after 1 o'clock. I wonder if now is a good time to break. I've probably got about half an hour left of questions to ask Dr. Gabra. A few documents taken too from his time in Birmingham and the West Midlands, but not terribly much.
Yes. Well, I wondered how much you had to go. I think given that it's half an hour, yes, we'll take a break now. So we'll come back at 2 o'clock, please, Doctor, if that would be all right. So 2 o'clock, and then we shall shortly after that finish the questions which Miss Scott has to ask, and there would maybe be a further short break before the last round of questions which those who've been listening will put forward to Miss Scott for her to ask you. So 2 o'clock.